Good morning, everyone, and welcome to the Regional Hypertension Summit. My name is Lisa Neff. I'm a Senior Community Impact Director with the American Heart Association, and I'll be serving as your MC for today. First and foremost, welcome and thank you. You're helping us as the American Heart Association in our important mission to be a relentless force for a world of longer, healthier lives. You are part of that today. You are on the front lines helping us with our mission and helping patients control hypertension to improve their health. We are holding this event today for a special reason. Today is World Stroke Day. Each year, approximately 800,000 people in the United States suffer a stroke, but strokes can be prevented. High blood pressure is a key risk factor for stroke. So by controlling blood pressure, we can help save lives. Now, we're going to cover several topics today, including hypertension guidelines and evidence-based blood pressure practices, all of which you'll hear about. But we'd like to start out by hearing from you. In the chat box, we'd like to know where you're coming from. You can see a sample of what that looks like on your screen today. Please make sure you're chatting to all panelists and attendees so everybody can see your messages. I'm joining you today from somewhat sunny and a little bit brisk this morning when I took my walk, but Buffalo, New York. If you can let us know where you're coming from and also what organization you're with, it would be wonderful to see that today. We'll give folks a few minutes just to familiarize themselves with the chat box and get to know how to do that. A couple other housekeeping items. If you'd like to share what you're learning today, please use hashtag #CheckIt and add us at AHA New York, all spelled out, on Twitter, Instagram, and Facebook. Again, we are in what we're calling right now the main room for today's event. When we get to the breakout session starting at 9 a.m., you will be leaving this room to join a separate webinar. If you have not registered separately yet, don't worry, there is still time. Please visit the website heart.org/regionalbpsummit, heart.org/regionalbpsummit. From there, you'll be able to register for your breakouts of your choice. If you do register now for a breakout session, please make sure you're checking your email because you can actually add it right to your calendar from the confirmation email. That's going to be the easiest way to get to it for you and know when you're going to go to those rooms. And again, if at any point today you have trouble, somebody will be staying in this main room for the duration of the event from 8 a.m. to 1 p.m. today, and we're happy to help you get to where you want to be. Before we get started with today's summit, I have to thank our generous sponsors that made today possible. Regional sponsors, St. Joseph's Health and Mount Sinai, South Nassau, and our track sponsor, Healthy Connections. And also a thank you to all of our speakers and presenters today. And today's summit would not be possible without these amazing volunteers and staff who we see on your screen right now. These are members of our planning committee and other staff members who work behind the scenes constantly to make sure that events like this function seamlessly. Thank you for your time and relentless commitment. Throughout the summit, we are going to hear from amazing speakers and panelists, but we do want to hear from you. Not only do we want you to tell us where you're coming from today, we encourage you to use the chat box feature to engage with the speakers and panelists. There are going to be staff and others that are monitoring the chat box for your questions, and we do want to hear from you today. If you do have questions throughout sessions, put them in to the chat box. We are going to hold questions till the end of most sessions, but we will keep a running tally of all those questions so we make sure you get your questions answered. Also, you do have a feature today to raise your hand in most of the breakout sessions, I should say. If you have a very technical question that you're not sure about, you're welcome to raise your hand. If it's just something that doesn't translate well into that chat box, raise your hand and somebody will be able to actually pull you off of mute during our session so you can ask your question live and make sure that it is understood by our panelists and speakers. All of our breakout sessions also, so you know, are scheduled for 45 minutes, with the exception of those that are in the Measuring Accurately track that will take the full duration of the hour. We did that strategically so you have time to transition between the webinars, because again, you should have 3 separate webinar registrations for today. And that's to make sure that you can get from this main room to your breakout sessions. During those transition times, we do encourage you to get up, move more, take a break, and make sure that you are ready to go into your next room. All right, I think that's it for housekeeping today, but if you do have questions, again, you know how to use that chat box. At this time, Dr. Canner, will you join us to introduce our first speaker?
Good morning. I'm Dr. Lawrence Canner, Chief of Cardiology and Director of Electrophysiology and Arrhythmia Services at Mount Sinai South Nassau in Oceanside, Long Island. Mount Sinai South Nassau, the Long Island flagship hospital of the Mount Sinai Health System, is proud to be the Regional American Heart Association Life is Why sponsor on Long Island. We have been collaborating with the Long Island market for many years and know the tremendous impact we have made together. It is my pleasure and privilege to be participating in this Regional Hypertension Summit, recognizing the importance that the American Heart Association consistently places on hypertension control. I would like at this time to introduce you to Dr. Howard A. Zucker, Commissioner of Health for New York State. As the state's chief physician, he leads the Department of Health's public health initiatives and oversees its healthcare workforce and healthcare facilities. He has been managing New York State's response to the COVID-19 pandemic and has worked at the helm on all critical health issues. Ladies and gentlemen, Dr. Zucker.
It is wonderful to be joining you virtually this morning to welcome you to today's New York State's Regional Hypertension Summit. Today brings together New York State's health systems, federally qualified health centers, and independent clinics, physicians, pharmacists, dietitians, home health care workers, and agencies, and others who all have critical roles addressing and reducing the burden of hypertension in New York State. This summit comes at a time when public health is at a crossroads. Clinicians, public health professionals, government officials, community leaders, and others must chart a course not just for a post-pandemic future, but for what the role of public health will be in the lives of Americans in the years and decades to come. This pandemic is, believe it or not, nearing the 2-year mark. Over the past 22 months, the Department of Health has been laser focused on fighting the COVID-19 pandemic at every turn. From shoring up our health system during the spring 2020 COVID-19 surge and instituting a system of hospital surge and flex when New York was the COVID epicenter of the world, to charting a safe reopening and bringing our infection rate to the lowest in the nation, to most recently getting the COVID-19 vaccine to as many New Yorkers as possible while continuing to contain the Delta variant. However, as this summit underscores, the chronic health concerns like hypertension and countless other threats to health have not gone away with the emergence of COVID-19. If anything, the pandemic has exacerbated other health issues by making it harder to access critical routine and preventive care. As such, despite our ongoing focus on COVID-19, the Department of Health remains committed to addressing all the other health threats New Yorkers continue to face. We are living in a time when once in a generation or even once in a century, health crises seem to happen with increasing frequency. This is similar and not at all unrelated to how often we are seeing once in a generation weather events. Just 2 months ago, storms generated by Tropical Storm Henri set records for rainfall in New York City, only to be outdone less than 2 weeks later as storms from Hurricane Ida pummeled New York City, killing dozens of people in the greater New York region. This is how our threats to public health have unfolded over the past several years, with the measles outbreak in New York just 2 years ago, crises of gun violence and mass shootings, an unprecedented rise in the number of drug overdoses, not to mention a global pandemic whose death toll in the United States now surpasses the 1918 influenza pandemic. Through all of this, the Department of Health has balanced and will continue to balance these emerging issues facing New Yorkers. From balancing water quality issues with cancer prevention, to balancing infectious disease outbreaks with smoking cessation. Though the public may be focused singularly on the health emergency dominating the news cycle, that is not the case for the Department of Health. So as we look ahead to a not-so-distant future when COVID-19 is another endemic viral threat, we must frame COVID-19 in the context of these other threats to the health and well-being of New Yorkers. And it is fitting that we start with hypertension, the most important modifiable risk factor for cardiovascular disease, which is a leading cause of death in the United States and in New York State. In New York State, nearly 1 out of 3 adults have hypertension. However, only 2 out of 3 of the individuals with hypertension have it under control. The problem of hypertension in New York State is not at all separate from the COVID-19 pandemic. In fact, individuals with hypertension have a 3-fold increased risk for hospitalization related to COVID-19 compared with adults without hypertension. And as is true with COVID-19, hypertension does not impact all New Yorkers equally. There are significant differences in the prevalence and control of high blood pressure based on race and ethnicity. The major burden of hypertension in New York State occurs in non-Hispanic Black adults with a prevalence of 37.1% compared to non-Hispanic white adults at 30.1%. COVID-19 underscores the urgency with which we must double down on our efforts to address these disparities in hypertension in partnership with trusted community leaders across the state. Existing health disparities in chronic conditions like hypertension are magnified when coupled with the existence of a respiratory illness like COVID-19. However, while these disparities persist, we know that it is possible to make meaningful strides forward in preventing morbidity and mortality by addressing high blood pressure, thanks in large part to the efforts of those of you joining us today. Research shows that just a 12 to 13 millimeter mercury reduction in systolic blood pressure has the potential to reduce the number of strokes by 37%, coronary heart disease by 21%, and deaths from cardiovascular disease by 25%. So how is the Department of Health working to get us there? The Prevention Agenda 2019 to 2024, New York State's Health Improvement Plan, serves as the blueprint for state and local actions to improve health and well-being of all New Yorkers and to promote equity across populations experiencing these disparities. The Prevention Agenda includes best practices in improving hypertension control and management in alignment with the activities promoted by the Million Hearts Initiative. The Million Hearts Initiative, co-led by CDC and CMS, aims to prevent 1 million heart attacks and strokes. One central tenet of this program is achieving an 80% control rate for patients diagnosed with hypertension. The American Heart Association and the American Medical Association Target BP program provides tools and resources for healthcare teams to develop and launch home blood pressure monitoring systems. Additionally, the Department of Health is working with the Community Healthcare Association of New York State to support FQHCs in implementing strategies to improve hypertension. This initiative takes advantage of health IT to identify and address gaps in care, as well as community-based organizations to ensure hypertension management and support continues beyond the walls of the health clinic. And later today, you'll hear about an innovative project focused on the use of health information exchanges to build hypertension registries, enabling clinical decision support that guide clinical action. The focus of today's summit, the MAP framework, emphasizes the importance and benefit of accurate blood pressure measurement, the M, measuring, initiating therapies that can combat high blood pressure, and then adhering to those treatments both through follow-up appointments and in the context of the patient's everyday life, which is A, for acting rapidly, and addressing the barriers to treatment adherence in partnership with patients that can effectively empower them to get their blood pressure under control, the P, the partnership. Today's summit is an important step forward in both discussing best practices in blood pressure management, but also improving the overall health of our patients. One of the key lessons we learned from the COVID-19 pandemic, and there were many, is the importance of our focus on public health prevention and preparation. This is true for blood pressure management, all chronic disease management, infectious disease outbreaks, environmental health concerns, and everything in between. Our experience with COVID-19, as well as our experience managing hypertension, show us the value of monitoring and surveillance and of sustained investments of resources into a robust public health infrastructure. This infrastructure must be built with community partners, especially those disproportionately impacted by the health issues we aim to address, and must be nurtured and supported over the coming months and years. With COVID-19, we see that this investment ends up being made eventually. The question is whether it happens to prevent a crisis or once the crisis has unfolded in order to respond. One critical component needed to effectively prevent public health issues down the line, which is equally applicable to hypertension, COVID-19, and others, is trust. We see trust appear prominently within the MAP framework to address hypertension. Without mutual trust and understanding, patients don't adhere to their courses of treatment or schedule follow-up appointments. It's important that we talk about trust, especially at a time such as this, where we all are working to address unprecedented threats to health at such a politically tumultuous time in our history. I believe that one of the biggest threats to public health that remains today, and one I have yet to mention this morning, is mistrust. Not just mistrust in vaccines, but mistrust in government and in science as a whole. This isn't just anecdotal. It is actually borne out in research. In a Pew Research Center paper examining public trust in government between 1958 and 2015, the American National Election Study asked participants, how often do you trust the federal government to do what is right? In 1964, 77% of respondents answered that they did. However, this fell to just 36% within a decade. Since 2007, fewer than 3 in 10 Americans expressed trust in the federal government. And this brings us to today, when COVID-19 is now largely a preventable illness, yet still a significant proportion of the population not only refuses the vaccine, but worse, pushes back against any efforts to prevent illness such as wearing masks. So how do we effectively build back trust? We saw this issue come to the forefront 2 years ago when we were working to address the measles outbreak in the Hudson Valley. The way we built trust and ultimately ended the outbreak was working hand in hand with local providers and community groups, letting them take the lead and forging relationships based on a mutual responsibility to take care of one another. By working with local partners, we administered 85,000 MMR vaccinations and increased the MMR vaccination rate among affected communities by 11%. This all goes to show that trust cannot be built from the top down. It starts at the local level and it works its way back up. Only by partnering with patients, the P in MAP, can we then make the necessary changes that prevent illnesses and ultimately save lives. And the true experts on how to improve health of New Yorkers and how to build back the trust are all of you, the clinicians, the community partners who are joining us today. Before I close, I want to take a minute to thank all of you for joining us at this summit today. Not just for your continued commitment to addressing hypertension in New York State, but for your dedication to supporting your patients and your communities in the face of all the threats to health. The expertise we have joining us today is unmatched, and all of the work the Department of Health does to protect public health would not be possible without the collaboration and support of those joining us today. As I reflect on my 7.5 years as the Commissioner, the challenges we have overcome as a state and the progress we have made is thanks to all of you. You are in many ways the eyes and the ears of the department into the health of New Yorkers, and it has been such a pleasure and such a privilege to lead this department and work with all of you in this role. It is my hope that COVID-19 and this moment will be a galvanizing force to make prevention, preparation, and improved public trust a focus moving forward and a sustained reality in the decades to come. Thank you.
Good morning. I'm Leslie Paul Luke, President and CEO of St. Joseph's Health, based in Syracuse, New York. St. Joseph's is proud to be a regional sponsor of today's Hypertension Summit. We're equally proud of our U.S. News and World Report Best Regional Hospital, as well as HealthGrade's America's 50 Best designations that were made possible by the contributions of our nationally recognized Cardiovascular Institute. I would be remiss if I didn't acknowledge the strength, resiliency, and tenacity of the entire St. Joseph's Health workforce during these difficult times. They amaze me every day, and I value their commitment to our mission and to the health and well-being of this community. It is an honor to represent them here today. It's also an honor to partner with the American Heart Association as sponsor of today's summit. We both share a commitment to advancing awareness, technologies, and treatments that help fight heart disease, which is still the leading cause of death in the U.S. The American Medical Association's MAP-BP is Trinity Health's national strategy for blood pressure control in the ambulatory setting. This year, we have been recognized as a Target BP Gold Plus site, which means we have achieved hypertension control rates above 70%, while also attesting to evidence-based blood pressure practices. It's a recognition we're very proud of, and I encourage you all to participate in the Target BP program. Through this program, we can make a real, measurable difference in the health of our communities. Coming later today, we'll recognize health systems across the state that have already achieved success in the program. Right now, it's my honor to introduce one of our keynote speakers to share more about the Target BP program. Dr. Michael Rakotz currently serves as Vice President of Health Outcomes at the American Medical Association, where he oversees efforts to develop and implement national quality improvement initiatives aimed at improving blood pressure control and preventing cardiovascular disease. He is the AMA's clinical lead of Target BP, a nationwide multi-year initiative in collaboration with the American Heart Association. Please welcome Dr. Michael Rakotz for A Map for Better BP Control.
Good morning, everyone. Thank you, Les, and thank you, everyone, for attending this morning. I'm really excited to be here and have a chance to talk to you all about what the AMA and AHA are doing to improve blood pressure control in New York and nationally. Next slide, please. So the agenda today, very straightforward. I'm going to talk a little bit about the current state of blood pressure control in the United States, explain what the AMA MAP-BP program is and the evidence for using it. And I'll go into a little more detail on dashboard metrics and monthly reports available to improve blood pressure control and prevent cardiovascular disease. Next slide, please. I also, just to say, I have no conflicts of interest or disclosures. So let's first, so you've heard a little bit this morning about cardiovascular disease and hypertension in the state of New York. I wanted to bring that to a little more of a national lens to get a better idea to you about what's happening across the United States. Next slide. So you all know that high blood pressure is common. This is from NHANES data, the most recent NHANES data set using 130/80 per the 2017 AHA-ACC guidelines. So this is prevalence of hypertension. And as you can see, while blood pressure traditionally using 140/90, you heard that about 1 in 3 people in New York have hypertension. Nationally, by about the age of 50, half of adults in the United States will have hypertension by this definition, and a vast majority over age 75, over 80%, close to 85% will have hypertension. So this is something that we're going to have to deal with in most age groups in the United States, really, starting in the 20s. It gets extremely common and even more common throughout the life cycle. Next slide, please. So high blood pressure is common. So how are we doing with controlling blood pressure? Well, you can see, looking at the graph on the left, that in 1999-2000, we had about a 30% control rate for high blood pressure. And we improved significantly over the next decade and into 2014, 2015. We peaked in 2013, 2014 at about 54%. But since that time, we've had really 5 straight years of decline. We're now down, we've given back almost 10 years of improvement in blood pressure control. We're now back to about a 43 to 44% control in the United States for those with a diagnosis of hypertension being controlled. A significant decrease, and the trend is not good, and this is all pre-pandemic. Next slide. I think it's also important to say that there's about 120 million people with hypertension. And the impact of hypertension, of course, we talked about it being the leading risk factor for cardiovascular disease, the leading modifiable risk factor. It accounts for about 50% of heart disease, stroke, and heart failure cases in the United States and around the world. 40% of deaths in people with diabetes are attributed to hypertension. And it's also a leading risk factor for fetal and maternal death in pregnancy, cognitive decline, renal failure, blindness, and other many other conditions. Some that are listed here and some that are not. So really crucial, a health factor, risk factor that we need to do a much better job around the world controlling, but in particular in the United States where we're going in the wrong direction currently. Next slide. So one way to gauge, the leading cause of death we talked about is cardiovascular disease, heart attacks, and strokes. And again, we had 30 straight years of essentially improvement in this area. We dramatically reduced the number of deaths, which we saw low in 2010. But since that time, very much correlating with the decrease in blood pressure control, we've seen an increase in deaths from cardiovascular disease. Very concerning to see this 30-year trend end, and now we're headed in the wrong direction. And again, hypertension, the leading risk factor for heart attacks and strokes. So on the next slide, if you want to prevent 1 million heart attacks and strokes, if we could please advance to the next slide. This is the CDC and Million Heart Strategy, which you've already heard of once this morning. The goal here is to prevent 1 million heart attacks and strokes. And this is data borrowed from the CDC. If you want to prevent 1 million heart attacks and strokes, what should you focus on to do that? What will give you the most impact in reducing heart attacks and strokes? And as you can see here, moving people with hypertension to blood pressure control far and away is the most impactful, preventing heart attacks and strokes by far, more than any other risk factor or health condition. Next slide. So as a result of this, in 2020, last year, the US Department of Health and Human Services, the Surgeon General, had a call to action to control hypertension in the United States with 3 main goals: to prioritize blood pressure control nationally for organizations, communities, health centers, practices, to cultivate community supports, extremely important, and to optimize patient care, all under a strong effort to incorporate health equity across all 3 goals in all these areas. Today, we're really going to focus on optimizing patient care, and just to lay this out broadly with the strategies listed here. And I'm going to go into a little more detail about how you can improve blood pressure control and optimize patient care. Next slide, please. So I mentioned earlier that most of the data that I presented so far was pre-pandemic, and the impact of the pandemic has been substantial. We don't necessarily have data to say what's happened to blood pressure control across the United States due to the pandemic, but what we have seen is a significant fall off from where we were in 2018. This is, for many obvious reasons, but one that may not seem so obvious, but I think it will after we talk about it here, is that office-based visits in the second quarter of 2020, when the pandemic really hit, there was a 50% decrease in office visits. And we know blood pressures are largely measured in office settings for the diagnosis and treatment of hypertension. So we saw about 59 million visits disappear in that second quarter of 2020 compared to 2019 and 2018. At the same time, we did see about 35 million new visits from increase in telehealth visits, which is fantastic. The problem there is, while at most office visits, blood pressure is measured, and telehealth visits, blood pressure was assessed less than 10% of the time. And this is a major concern. We were really not prepared to remotely monitor blood pressure on such a large scale when the pandemic hit. And this is the concern here, is that this will adversely affect blood pressure control because there's a lack of blood pressure measurement data for all of the visits that have been missed. And this impact could be significant, and it appears to be significant as we look at the preliminary data. Next slide. So let's talk about what we can do and what we have been doing really for the last 10 years now to try to improve blood pressure control at the American Medical Association in conjunction with the American Heart Association. The next slide. So we created the MAP framework with Johns Hopkins with a team of quality improvement experts and a team of health equity experts, again, about 10 years ago. And the framework you already heard once today: measure blood pressure accurately. M means we're trying to get accurate and representative blood pressures every time they're measured. Accurate meaning that the blood pressure measured is close to the blood pressure in the artery, and representative meaning the blood pressure that you measure isn't just a snapshot in time, but is more representative of what the patient's true blood pressure is throughout the day and at home. So measure accurately every time in or out of the clinical setting. Act rapidly to treat uncontrolled high blood pressure, to initiate and intensify therapy, and partner with patients and their families to support them in living healthier lifestyles, in adhering to treatment, using collaborative communication strategies, promoting healthy lifestyle change, using self-monitoring. So a lot of support in this area. This is a critical aspect of the framework. So MANP, this is the MAP framework that we use to create a quality improvement program that I'll talk about on the next slide. So we took that framework, we created a series of checklists, and we wanted to have a little bit more structure in a formal program that would be easy to follow, that could have lasting impact. So next slide. So each component, I'm sorry, go back one slide, my apologies. Each component of the program has very straightforward evidence-based strategies and action steps that clinical teams can follow, supporting tools and resources that make it a little bit easier to do that and audit the program and track over time. We provide clinical implementation support in the form of doctors and nurses and quality improvement specialists that can really help make that change happen at clinical sites, at the primary care patient level and even the specialty level. And finally, really going to emphasize today the importance of performance metrics, process metrics that we use, dashboards to visualize those metrics, and monthly reports to really get tactical on identifying people who need help improving blood pressure control. Next slide. So the metrics that I mentioned, we think it's really important to have data in front of healthcare organization leadership, quality improvement teams, pop health teams, and primary care teams, really the frontline healthcare workforce. These metrics help really understand the impact of the process change that you're trying to make, and to be able to track those individually over time to look for gaps in the management of hypertension. So the first metric for M, the confirmatory BP measurement, looks at the percentage of the time that a structured measurement protocol is followed, which will help get those accurate representative blood pressures. The therapeutic intensity metric shows the average number of BP medications prescribed at standard dose or higher across a population. The idea here is that we know most patients will need 2 or more medications to get to goal, and this will give you a very quick snapshot of time. And in many cases, we know that 40 or 50% of people with uncontrolled high blood pressure are on 0 or 1 medication. So this really helps shine a light on therapeutic intensity and the importance of it, and where there might be gaps. We also, for P, we have 2 metrics. One looks at the systolic blood pressure change on the visit after a therapeutic intensification. It is a proxy for medication adherence and treatment effectiveness. And this has been very helpful, and we've seen significant improvement here with using the program. And visit follow-up, what % of the people who have uncontrolled high blood pressure, whether they're diagnosed or not in most cases, what percentage of the people with high blood pressure come back for a follow-up within 30 days, either to get diagnosed or to have treatment intensified? And this is all compared to the one outcome metric that you're probably using, control rate, which really is the denominator is all of the people that are adults with high blood pressure, and the numerator is who have been controlled on their most recent encounter. So these are the MAP metrics. We use this to drive improvements. We found it to be very effective. Next slide. So looking at the results just very briefly, if you look on the left here, baseline blood pressure at 16 sites in South Carolina, primary care offices, very busy, 16,000 patients were seen during the 6-month intervention period. At baseline, blood pressure control was about 64%. Rapid improvement at 6 months, blood pressure control improved, an absolute improvement of to 74%. So a 10% absolute improvement, or 10 percentage point improvement in blood pressure control rates in 6 months. At that point, the formal coaching for the program ended. We withdrew our clinical support, and at 1 year, over 90% of those gains in blood pressure control were maintained. I will say that the practice sites had access to the dashboard for the rest of that time and continuously since then, and maintained blood pressure control rates that were similar to the 6-month time period. Very unusual in a blood pressure improvement program, but we were really thrilled with these results. And at this point, having seen statistically significant improvement in all 3 components of the program, we decided, and the outcome measure, we decided to roll this program out as widely as possible across the country. Next slide. Once we knew that the program was effective, we formalized our collaboration with the American Heart Association to prioritize blood pressure control nationally and encourage healthcare organizations across the country to do the same by joining Target BP, by taking steps to improve blood pressure control at their organizations, and to receive national recognition for doing so. And Target BP has been extremely successful. Over 1,000 healthcare organizations every year are submitting data into the recognition program. I know you're probably very familiar, but we're really proud of this collaboration with the American Heart Association. It's been extremely successful, and we're looking forward to making it even more effective. Next slide. And at the same time, while focusing on Target BP and collaborating with Million Hearts at CDC, we have been at the AMA rolling out the MAP BP program formally across the country, really in about 24 states now, and increasing our footprint, trying to help healthcare organizations from academic medical centers to community health centers and to medical groups really try to focus on prioritizing blood pressure control successfully. Next slide. So I'm going to talk a little bit more in a little more detail about dashboards, data, and reporting. And we really have 3 strategies here to try to get data in front of clinical teams across the country. And again, pop health teams, quality improvement teams, to really try to drive the improvement needed to improve blood pressure control. On the next slide, you'll see this, we think the importance of having this dashboard really gives an accurate picture of what's going on in a healthcare organization, whether it's a health center, whether it's a large medical group. You can look across the population of patients, whether it's at a site, whether it's at the system level, whether it's at the provider level, and really see what these metrics are doing to try to identify gaps in hypertension care so that you can focus the process change that is offered in the program with tools and resources to try to close those gaps. And we'll go into a little more detail. This is something that the AMA actually hosts with your organization or can embed into the EHR in some EHR systems to try to make it extremely convenient. Next slide. So, we know that hypertension doesn't, live in a vacuum, and that the other risk factors to prevent cardiovascular disease like diabetes, high cholesterol, and even preventing type 2 diabetes. We have dashboards and metrics for all of these, and we're currently building out more formal programs and testing them in each of these areas. But we knew that we had to move beyond hypertension only. So these dashboards are all available for organizations that we collaborate with. Next slide. And just without going into a lot of detail, you see that each of the metrics that I mentioned are easily visualized, and you can compare a provider to another provider. You can compare a provider to a site or sites with each other. On the left in the large dial, you see control rates. This is between a physician and their health system. The physician's control rate is 51%. The health system's control rate is 73%. And you can do that for each of the metrics. I want to point out here, there's a filter function for the metrics specifically. And while you can see the metrics and look at them in these groups, you can actually filter the metrics across race and ethnicity, sex assigned at birth, gender identity, age, and comorbid conditions to really find out whether there are gaps within any subgroup within your population. And again, this gives a snapshot for the average for these metrics across a group, which I think is extremely useful, especially for surveillancing how individual providers or sites are doing. But we also felt that it was really important to create specific patient level reports to really drill down and have actionable data that can be used during an encounter in a clinical setting. So on the next slide, I'll start to go into this just shows how we can use trend feature of the dashboard. This is actually visualized with the dashboard so that care teams can see month-to-month improvement, sort of the fruits of their work to improve. They can see these averaged out over 12 months, so they can compare month to month to see how they're improving with their metrics, which many find extremely useful. Next slide. So the reports, the dashboards available at the system level, as I mentioned, at the site level and at the provider level, these downloadable summary reports that really go down to specific patient levels are, they're available again for the sites to compare each site, for the providers to be compared to each other. And I think most importantly, at the patient level, to really, for a provider and a care team to look at a group of patients that are either coming in or need intervention to improve blood pressure control. And on the next slide, just quickly go through some quick examples here. This is looking at control rate across one provider's patients or a site's patients. And you can see that in red, people who have uncontrolled high blood pressure show up. Easy to sort them based on systolic blood pressure or race or ethnicity or gender or age or comorbid condition. And you can very quickly decide how you want to prioritize getting these patients reevaluated to get them to goal, or perform outreach, bring them in, or even who needs a blood pressure assessment, whether that's at home or in the clinical setting. So this makes it very easy to get actionable data to the primary care team. On the next slide, you'll see another report that we provide. This is a huddle report or a gaps in care report that can be used for a group of patients who are coming into any clinical setting that day. And it's really focused on cardiovascular disease. It focuses on ASCVD risk and hemoglobin A1C and cholesterol and blood pressure, with some suggestions for what might be needed, what might be some potential gaps, just possibly something that can be used in a daily huddle report. On the next slide, you'll see something that we think is probably one of the most important reports that we have on prescribing. This is a number of people who are uncontrolled with the diagnosis of hypertension and how many medications they're on. 0 medications, 1 medications. And as I mentioned earlier, you can see from this example, close to 40% of patients who are uncontrolled are on 0 or 1 medication. So a lot of opportunity to improve intensification to get people to BP goal. And on the next slide, we can actually look at what medications are being prescribed across a healthcare organization so that you can know if guideline-directed treatment is being used, guideline recommendations are being followed, are patients being dosed appropriately, and you'll get a very quick idea what's being used and what's not being used. And I'll say that there's often a disconnect between what providers think that they're using to treat a population of patients with hypertension and what they are actually using. So if there are non-recommended medications being used across organizations, which we often see, there can be some education centered around that to try to improve guideline recommended treatment. Next slide. So as we start to wrap up here, I'll just say that, so that's the AMA MAP-BP dashboard and reports. We're also collaborating with the American Heart Association, has a fantastic outpatient registry pilot. I think you'll hear more about that later today. It incorporates the MAP-BP metrics for blood pressure, but also includes metrics for other conditions like high cholesterol and diabetes. Very similar the way that it works with metrics. This is a pilot project currently in testing, but hopefully will become more widely available over time. But another great way to get data in front of people to improve the management of chronic conditions. And finally, the third way that we're trying to leverage data on the next slide is that we're collaborating with population health vendors who already have dashboards in many parts of the country, especially in community health centers. Two of these vendors alone can reach 60 million people on dashboards with data and metrics. And so we've just formally signed an agreement with Azara that will potentially give us access to 8 million people with hypertension in health centers across the United States. So we're really excited about the opportunity to have MAP metrics and the opportunity to offer coaching and support to implement MAP-BP at these sites to try to move that national blood pressure control higher. Next slide. And we're just about to wrap up here. So I would be remiss on the next slide if I didn't mention self-measured blood pressure monitoring or home blood pressure monitoring. The American Heart Association, the American Medical Association came out with a joint policy statement that is really, it reads like a scientific statement. It has the latest evidence on indications, techniques and training, device accuracy, effectiveness of lowering blood pressure using SMBP, and cost effectiveness and barriers, coverage, and quality. It's a really easy to read manuscript that I think will give you what you need to know. We talked earlier about during the pandemic, such a decrease in office visits and an increase in telemedicine visits and home blood pressure monitoring. You really have to do that in a very specific way, using evidence-based guidance for it to work to lower blood pressure control. So it's not enough just to have those blood pressure home measurements, but you actually have, you have to know what is a guideline, evidence-based recommended protocol that works to use them, and what are some techniques to use home blood pressures to lower blood pressure and improve blood pressure control. Also, we've collaborated to create the U.S. blood pressure validated device list, knowing how important having a validated device that is validated for clinical accuracy for use to manage patients with hypertension, and that is available at validatebp.org. And I know we're at time, and I just wanted to allow plenty of time for questions that you can enter in the chat. would love to answer any questions that you might have, and looking forward to those of you who will be in the breakout session on treatment intensification. But thanks very much.
We do have some questions from the chat.
Great.
We have a question: what percentage of patients were people of color, and did you look at SES? What things did you do to facilitate behavior change?
Yeah, I mean, that's a really great question. And I'm assuming that, it's referring to the data from the study that I showed in South Carolina. I don't have, in that manuscript and the references there, we have a breakdown of the patients who were seen by race and ethnicity. It was in South Carolina, in an area that is considered in the stroke belt. So there was good representation across, at least there was a listing for Black adults or African-American adults in that population. And what we found, and we didn't talk about this in the publication because it was the first time we had seen this with MAP-BP. I told you MAP was designed with, it was designed with Lisa Cooper's team at the Center to End Health Disparities at Johns Hopkins. And what we found in South Carolina was a 50% decrease or reduction in the disparity between Black and white adults with uncontrolled high blood pressure. In other words, the program was actually more effective in Black adults than white adults. It didn't eliminate the disparity in blood pressure control, but it cut it by 50%. We've recently taken a closer look, now that we're having more and more data in different organizations to look at this data. We just got the results in from a community health center that showed the exact same 50% reduction in the disparity between Black and white adults with hypertension. And so while we haven't eliminated it, which is our goal, and we're continuing to work hard to do that, we're consistently now seeing a reduction in that disparity. We did not formally assess social determinants of health in that study that was done in 2015, but we're starting to do that more, and we need to do that more. But we did assess diet, physical activity, or sedentary lifestyle, and sodium intake, recommending, there are a lot of people eating the Southern diet, and we did formally, and alcohol in moderation. So we did formally assess, well, I should say informally assess those things. That's part of the program in T, in partnering with patients, but we did not assess social determinants in the same way that we're trying to do that now. So we're hoping to have more evaluation and analysis of that data in the next year.
Our next question, any review of Black immigrant versus Black US hypertension control data?
That's a great question, and we do not have, we have not done that yet, although it's something that we've talked about doing and we'd like to have more data on. We're in the early process of rolling out the dashboard across the sites that we're working with, and it's only when we have the dashboard that we have the ability to look into those data. And a majority of the MAP implementations that we've done so far, based on our initial strategy, was to go out and hope that sites could build these dashboards and use these data and metrics without sharing their data formally. And that wasn't as, we found that didn't work as well as when we could actually share data and display the data in the form of a dashboard and reports. So we didn't, for a lot of what we've done, we didn't have that data and the ability to sort that data and then analyze it. We are starting to now, and that's a great question. And we're really looking forward to being able to try to answer that, Sue.
Has MAP-BP been shown to reduce disparities?
Again, mainly right now, what we've looked at is it has for blood pressure control in Black adults versus white adults. So we have seen that reduction that I mentioned, a 50% reduction in control rate in the disparity there. So we're happy about that, but we're not resting on that, and we want to make sure that if disparities exist across all of the metrics, that we eliminate them. And we're working hard to try to collaborate with the health centers and medical groups and medical centers to try to do that. So we, more to come on that as we have more data and more testing.
Is MAP effective in community health centers?
Yeah, that's a really great question. And I can tell you that when we launched our dashboard service. So we, AMA provides this service currently, no cost to the organization. And we did it because we really felt that this is a really critical part of the program. And I will tell you that in the last year, for example, about 80% of the sites we're working with are community health centers, HRSA-funded health centers. And we have seen good results. Even during the pandemic, we've had some really great success stories in this way. MAP has been effective in health centers, and we, in the sites that we're working with right now, we're seeing the results that we want to see. So it's, this takes a lot of work across the board from the care teams prioritizing blood pressure control in spite of all of the competing priorities that they have. But where that's happening and where we're implementing MAP, it seems to be working in health centers and even large medical groups and academic medical centers as well. So it seems to be working, which is why we want to get as many healthcare organizations using MAP and the MAP-BP program as possible.
Our next question, have you seen the same outcomes in men and women?
We have, we have not seen large differences there. That's a really good question. In different groups, looking at national data, there are big differences in control rates between men and women, and even between men and women as people get older and the prevalence in women increases. We've seen actually, and national data, we published a paper on this year, that women in particular, as they age, this is a tangential answer to that question, but we're seeing that there is less blood pressure control in women as they get older compared to men. Especially over age 65, that has not been talked about so much. So it needs to be a renewed focus. And for our work, we're, again, we need to continue to repeat evaluating populations, but so far seems to be working well in men and women. But there's a larger disparity there that we need to close again. So in certain groups of people. So it's challenging. It needs to be a priority, and teams across the country are working hard to do that. So. Can't say that it eliminates the disparity there, but it definitely it's been helping quite a bit.
We have another question. Is there any work being done to increase insurance coverage of remote monitoring services for FQHCs and increasing blood pressure monitor device coverage by insurance for self-monitoring?
Yeah, that's a really great question. And I'll say that the teams at the American Heart Association and the American Medical Association are working together to try to expand coverage, to expand Medicaid coverage, and to expand coverage of these devices in states across the country. There has been a lot of success in the last few years expanding Medicaid coverage for devices. And what we're really focusing on right now is that the quality of that coverage. We want that increase in Medicaid coverage to include devices that are accurate, so validated devices that have multiple cuff options so that the devices actually work well in people who have big arms and small arms, that they can get cuffs specifically that fit them, because without an appropriate cuff size, you can't get an accurate blood pressure. So we're working very hard to make coverage happen, not only, in Medicaid across the country, for health centers. We think that it should be a covered benefit for all people in the United States to have access to a validated device with multiple cuffs. And we are going to continue to work until we can make that happen. We're hoping, we've got a coverage determination pending, a non-coverage determination pending with CMS now, AMA and AHA, to try to expand coverage within CMS as well in Medicare patients. So, and if that happens, we typically see multiple payers follow suit there. So making some progress. We hope this year. We're really pushing hard for that. That has been something that the AMA, again, and AHA teams are working tirelessly to try to make happen. It's been difficult, especially, again, with competing priorities of the pandemic for obvious reasons.
We have reached the end of our time, but we will save questions that haven't been answered. For anyone who didn't get their question answered, we will get it to you. Thank you very much, Dr. Rakotz.
Thank you for having me.
Dr. Rakotz, that was wonderful. Thank you so much. We are about to head into our first breakout session of the day. In a minute, again, please, this room is going to stay open. If you have not registered for your breakout sessions yet, please go to our event website, heart.org/Regional BP Summit. On the right hand of the screen, you'll be able to select right hand of the screen, be able to select the sessions of your choice. Please select one breakout session for our first session and one for our second that will be coming an hour later. Right now, you do have 5 minutes to leave this room to get to your breakout session. Please take that time to get a stretch break in and make sure you're ready to go. If you enjoyed Dr. Rakotz's speech and what he was talking about, he is also going to be joining us in the Act Rapidly session in Breakout 1. So you're welcome to move on into that room at this time. There are 2 other sessions that are going to be available, and those are the Measuring Blood Pressure Accurately and Remote Patient Monitoring in the 2 other rooms. So please make sure you are heading to your breakout session at this time. If you are having any trouble getting a confirmation for your registration, please raise your hand in this room and an American Heart Association staff member will be able to assist you. Thank you so much, and we'll be here, and we will see you back in this room at 11 a.m. for our keynote speaker. Welcome back, everyone. We hope you enjoyed the breakout sessions. Thank you to all of our panelists and presenters. Please let us know how you enjoyed those breakout sessions in the chat box. I've been hearing wonderful things from people throughout the 2 hours that you were all gone from this room. We will be together in this main room for the remainder of the summit. So no more external Zoom webinars that you have to hop into or anything else. We will be staying in this room together. Now, the American Heart Association has set an important impact goal. Every person deserves the opportunity for a full and healthy life. As champions for health equity, by 2024, the American Heart Association will advance cardiovascular health for all, including identifying and removing barriers to healthcare access and quality. We are looking at everything we do with a health equity lens. It's an incredibly important part of moving the needle on health for all. I'm proud to introduce our next keynote speaker, who will share the ways hospitals and health systems can address health equity. Dr. Keith Churchwell is the president of Yale New Haven Hospital. He has a background in cardiology and is currently serving on the national board of the American Heart Association as the chairman of the National Advocacy Committee. Please welcome Dr. Keith Churchwell.
Lisa, it won't let me start my video.
I just changed it for you. There you go.
All right. I think we've got it now. Well, thank you, Lisa. Appreciate that. Lisa has been after me for who knows how long. Actually, I don't know all the things that we have done together over the years. And it was just a pleasure to hear from her. And also just an honor, just taking the opportunity to actually have some time with you over the next hour. So I don't think this talk will be a whole hour. Hopefully there'll be plenty of time for questions in the chat, and also those who want to raise their hand about the subject matter that we're going to go over. It's been a topic of conversation for me over the past 20 months in particularly. And if you go to scientific sessions, it's actually, there are a number of sessions importantly talking as one of the next steps from last year's scientific sessions on health equity and structural racism that we have, I had the opportunity to be a part of and also to lead as we go forward. So I'm going to go ahead and actually share my slides and we'll get started. Here we go. I think we're good. Great. So I thought I'd talk a bit about hospitals and health systems and the work around addressing health equity and how we can enhance the overall delivery of care to the patients that we actually touch on a daily basis. And I think that actually is quite germane to the ideas of the Hypertension Summit. Hypertension, of course, being one of the significant risk factors and actually causes of morbidity, mortality, and cardiovascular and cerebral vascular disease across the country, if not the world. We continue to work on opportunities to improve the overall health of individuals and for populations with hypertension. And I'm sure that's been part of the breakout work. And hopefully today there'll be additional innovations that will come to the table of how their heart association can join with hospitals and health systems across the country to actually make a dent in this particular on this particular issue. So I thought it appropriate. I don't have any conflicts to discuss and no disclosures. So thought I'd start with just a little bit of data. The data really speaks to the issue in terms of healthcare and overall cost. And many of you have probably seen this slide in some form or fashion. This speaks to the amount of funding that we, from a government standpoint, from a system standpoint, we have seen and in comparison to industrialized countries across the world, United States versus many of those particular countries. And what you see is that healthcare costs and nation's overall investment in improving the health of Americans has continued to rise significantly over the past few years. Spending in terms of GDP in this country, it now approaches 18% of the total GDP, just for healthcare spending. And as you can see, in comparison to other industrialized nations, there is a much greater expenditure to pay for care and in comparison to others. And the question is always, since 1980, that particular significant increase in expenditure, what are we getting for that? What is that, with that investment, how is that actually, how can we quantitate the overall, hopefully, improvement in overall care? And particularly, how does that actually correspond to our ability to deliver care in an equitable fashion? This is actually data from the Commonwealth Fund, an analysis, and this is a paper that you can find actually on the internet. It's actually a very interesting paper, I thought, that talks about the issue of equity and funding, and actually does a comparative analysis for industrialized countries and with the US actually being in that particular analysis. And what you see from the Commonwealth is that on the scale of lower performing versus higher performing countries, that we fall actually at the bottom of the scale. How equity is being defined is actually is quantitated in a number of different ways. The features whether there is the data is upon measurements of access to care, care processes, and administrative efficiencies in terms of ability to provide care. The four features that actually distinguish the top performers from the United States are that the number one, they provide universal coverage and remove cost barriers. They have invested in primary care systems to ensure that high value systems are equitable and available to all. And that they reduce administrative burdens that divert time and efforts and spending from healthcare improvements. And they have invested in social services, and particularly, especially for children and working age adults. So as we look at our overall expenditure, we have to ask ourselves, as we have continued to actually grow the overall pot, are we actually investing in our society and in our health system in a way that actually will make care more equitable? And how can we approach that and actually move us in the right direction? I thought I'd touch on, as part of that, is actually work that Heart Association has been doing in this particular space that probably many of you have had a chance, hopefully, to read, and some of you may have been a part of this work. From last November, we published a presidential advisory on structural racism as a fundamental driver of health disparities. It was an assessment of work that has been done by the AHA over not just the past year, but actually over multiple years, which I'll touch on later. And then putting a framework in regards to the issues of structural racism and its impact in terms of the equitable delivery of care across our nation. And then thinking about a pathway forward. And I'll talk a bit more about that later in the overall talk. I did want to actually, though, as a construct, as we've thought about the issues of structural racism, realize that we are not calling institutions racist at this point, but understanding that the structures we have put in place actually have an impact and an impediment in our to be able to deliver actually the highest quality of care and equitable care across the country. And we have examples, and we put together a slide that I thought was actually very, very informative of thinking about, from the beginnings of the country, some over 400 years ago, those particular issues that have actually led to structures being put in place that we continue to have to fight against and actually define and think about activities and opportunities to improve, to resolve these particular issues, so that we can get to a more equitable place in terms of distribution of care and allowing us to actually be able to have a greater impact around for healthcare for the whole population. And a couple of examples of that were, of course, Jim Crow laws and redlining, the issues that we continue to face in terms of poorly funded schools, access to capital across neighborhoods, poor housing conditions and physical environments, which again, the HAA has enjoined and actually not only standing, but also moving towards a larger opportunity to improve. And also importantly, poorer access to healthcare and how to actually expand that. And all of that actually leading to an increase in risk in cardiovascular disease and stroke risk for the populations at risk, and especially in our brown and Black communities, coupled with toxic stress. So how should institutions address the issues of health equity? And as part of a thought about this, I thought it important that, number one, we have to understand what we need to, how we recognize our past. And that goes back to our previous slide, but importantly, I just wanted to pull out a few examples of how the past has really continued to have a tremendous impact in terms of our present on how we actually can address these particular issues. First example I wanted just to illustrate was actually the Flexner Report. The Flexner Report obviously has had a profound effect in the development of the modern medical school, and it cannot be overemphasized. But its impact on the persistent lack of physicians of color throughout our workforce can be directly tracked to its recommendations that the majority of our African-American-led schools within its publications and the limitation of their work to only sanitation and taking care of a limited population has had a profound effect in the development of and the population of African-American and Latino physicians in our country. We went from a significant number of medical schools that actually catered to and supported the development of African-American physicians in this country down to 2 by the recommendations of the Flexner Report. And in that had led to a significant limitation in terms of the expansion of the roles of those schools, and also significant limitations for many years for individuals who actually wanted to go into to obtain a medical degree to actually have access to that particular pathway within our school systems. Second is I think an illustration of an issue that I think many of you have actually had some both interest in and actually have actually read the book about, and that's actually Henrietta Lack, and that's a great example of her impact on Johns Hopkins. You know, at the time of Henrietta Lack's diagnosis and treatment and ultimate death from cervical cancer, Hopkins was a segregated institution who used her cervical cells for research, and has led to a revolution, which has led to a revolution in science. But for decades, her contribution and the fact that her consent and her acknowledgement for that use was ignored because of policies that were widely held and racist at the time of her treatment. With the publishing of the great book, Immortal Life of Henrietta Lack by Rebecca Schlock in 2010, there's been a recognition by Johns Hopkins of not only her contribution, but the impact of her previous policies has been important in the development of opportunities for greater interaction with the local community and with the Lack family. And just recently, the Lack family has now enjoined multiple institutions and a lawsuit and the issues around the utilization of her cells, the impact that it's had, and actually the fact that no financial remuneration has ever come to the family. And then third, as another example, is at Georgetown University and like University of Virginia and Harvard, the legacies of slavery and actually the impact of the slave trade on the development of these institutions and the acknowledgement of and thinking about how to go forward with that particular acknowledgement. At Georgetown, the wrenching knowledge that the survival of the institution in 1838 was really based upon the selling of 272 men and women and children from the Jesuits' Maryland plantations continues to be evaluated, and the need for an understanding and a pathway forward for the institution, the descendants of these remarkable people, is ongoing, about how, as an institution, you can reconcile this particular knowledge and think about the pathway forward of a degree of restitution, but also improving the overall equitable opportunity for individuals to partake of a higher degree of education for that institution and for other and multiple institutions. This is in the midst of COVID, I think importantly, the issues of health equity and social determinants has actually been, to a greater degree, even greatly more unmasked. This is a slide from Harvard Magazine, as they have done an interval assessment of the pandemic. And as they looked at the data by Shaw and others, the issues around hospitals and health systems and the need for them to have a greater impact around social determinants to improve the overall morbidity and mortality from COVID-19 has become very apparent. The issues around how institutions like ours and others can have improve the overall education access and the overall quality of education in the communities that we serve. How we actually can continue to improve healthcare and overall quality in a way that is both not only colorblind, but also fits the needs of the populations that we serve to a greater degree. That the neighborhoods that surround us that actually have significant impact on the overall health and well-being of the individuals that we serve have to have a significant improvement because of, at times, the toxic environment that our patients actually live in. Improving the overall social and community context so that there is a greater opportunity for the enhancement of education and the overall pathways of professional development for the citizens that we actually serve. And thinking about how we can also help in terms of the overall economic stability for the areas that we actually live in. I mean, in many cases, hospital and health systems are really the largest employer for the areas that we sit in. Within that's incredibly important, but as part of that, is there an opportunity for continued professional advancement and for social advancement for those particular individuals who actually work with us and beside us on a daily basis. So the other big issue in terms of for hospitals and health systems is how to pay for it. Is there a business case for health equity? What's interesting is data that actually has been accumulated by the Urban League that they published actually recently. And looking at the particular data, the overall cost to the system that happens on a yearly basis in regards to not actually addressing the issues of health equity and social determinants is over $82 billion per their calculation. $60 billion excess in healthcare costs and another $22 billion in lost productivity. So the economic burden of disparities is projected to be will be projected to be over $350 billion in 2050 if no changes occur. If we were able to improve the overall health outcomes and by making equivalent, the equivalency in terms of education between high school and college graduates, we would improve the death rate significantly, and that would translate to over $1 trillion saving in the United States. So the ROI actually with these numbers is readily apparent in terms of what the need for addressing the social needs for the populations that we serve to improve the overall health outcomes. And I think that's important data for us to understand. We have made investments, and the question would be how those investments have actually turned out over the past few years. And there's data actually that has gone forward to evaluate that. This is actually from a paper out of Health Affairs recently that looked at data from 2017 to 2019 and asked the question in the left-hand part of this slide of both examples of where we have made investments and the impact of those investments. And there have been investments in both housing and transportation, food security, employment and education and social community context by institutions that have been innovative and actually have led to improvement in the overall health and well-being of the populations that they serve. As you can see, both in Metro Health in Cleveland, Hopkins, Kaiser Permanente, and ProMedica. Montefiore has actually worked to address their housing issue with a significant investment in housing that surrounds their main campus for the homeless. And Kaiser Permanente has done the same actually in the Oakland area with over a $200 million investment. But when you look at actually all these investments that actually that are well over $2.5 billion, despite that, there has not been a significant improvement in the overall health of the population over the past few years. And it brings into question how we can actually work towards a more coordinated effort in terms of the delivery of those dollars in a way that actually that we can measure, that leads to actually improved outcomes and improved overall equity of care for our population. So here at Yale New Haven, and I think at other institutions, we have been guided recently by a framework that has been put together by the Institute for Healthcare Improvement in regards to thinking about health equity and the issues that surround it, and how we can actually improve the overall model that we have and then measure to understand how the things that we have done can improve the overall care and well-being of the population. Number one, as a hospital and health system, making health equity a priority, a strategic priority, we think is key. We must demonstrate leadership and be committed to improving equity at all levels of the organizations that we serve, and also think about this and develop secure, sustainable models of funding through both new payment models with insurance and with the government, so that the successful programs that are actually put in place can be sustaining in the long term. Number two, we want to be able to develop structure and processes to support health equity work. One of the things that I'm sure many of you have probably experienced is that our ability to actually think about the day-to-day operations and how they intercalate and integrate into our work and within the hospital health system is difficult. And we need to think about putting together a structure, a governance structure that oversees and manages equity work across organizations, across systems, that again will be sustaining and have a pathway of overall development and evolution, and make it so that these issues become really interdigitated into all of the opportunities that actually that come up within the healthcare environment. So in that, we must truly dedicate resources in the budget to support equity work. And I can't overemphasize that, because without that, it actually will fail. And will actually be, unfortunately, will actually be put by the wayside and put on the curb for institutions if we don't invest those dollars and resources. Number three, we need to deploy specific strategies to address the multiple determinants of health on which healthcare organizations can have direct impact. As a healthcare organization, healthcare services is something that we actually have expertise in developing and actually expanding. Bringing actually other organizations and individuals who actually have expertise in understanding the socioeconomic status of our patients, and supporting that in a way that actually has a community involvement. Again, bringing and being a convener of others who actually can help in terms of developing and enhancing the overall physical environment for the patients and in which they live. So that's actually talking to our local governments and also our regional opportunities, and thinking about those resources that are really a part of almost every neighborhood and every city that actually are working towards enhancing the overall environment. And establishing and promoting healthy behaviors for the population. Going out and actually being able to articulate those particular behaviors, to be able to follow, to be able to observe, and to measure, and also be able to discuss with everyone in the population in a way that is understandable, and also can be performed successfully, become part of their overall day-to-day work. We must decrease institutional racism within the organization. And that actually is really an understanding about where most institutions have evolved, what is our history, how as an institution we came to be, and are there issues that surround structural racism that we need to take into consideration to understand, to bring forth, to be able to put behind this and think about what's the next stage in overall development of opportunity within our organizations. Our health insurance plans accepted by organizations must actually be broad, and also give opportunity to every single person who actually comes through the door. And we must also reduce implicit bias within organizational policies, structures, and norms, and our patient care. And that is hard work. That is work that actually has to be done by the organizations in terms of learnings on a regular basis, and also opportunity to discuss and have open forums between all parts of the organization, so that there's a greater degree of understanding and an acceptance that we are all imperfect individuals, and there is work that has to be done by all of us in this particular domain. And number 5, we need to develop partnerships with community organizations, as I have sort of discussed above. We have to leverage community assets to work together. We, as a hospital and health systems, don't have all the answers, nor do we have all the expertise in terms of being able to resolve these issues and improve the overall our capabilities to improve health equity. We need to work with our community and think through the community issues that are related to improved health and equity, and develop strategies with our partners on how to do this and do this effectively over both the short and long term. So what are the opportunities? At Yale New Haven, we've thought about hypertension and hypertension being an important issue. Data that was brought to me by Dr. Erica Spatz, who's one of our spectacular cardiologists here, looking at our hypertension population, is probably consistent with the data that you have seen, that we don't treat hypertension well, and at times we treat it poorly. Just looking at the population of patients who actually have significant accelerated hypertension, malignant hypertension, who are coming to our emergency room on a regular basis, what did the data show her? Number one, it was actually the same patient population. These patients actually who came into our ED with those diagnoses came multiple times during the year, 3 to 4 times a year, same patient population. They were treated, blood pressure was lowered, they went home, they came back with actually accelerated hypertension. So there was a disconnect. Number 2, was also a patient population that actually had significant connections, not only to the community of New Haven, but also to Yale New Haven Hospital. Many of them actually worked in the hospital. So a unique opportunity to actually have a greater degree of relationship with a patient population that we could serve in a much higher way. So Erica and a group of cardiologists, primary care physicians, APPs, and pharmacy in particular, because pharmacy having the bandwidth to be able to connect with patients in a very unique way, have put together a remote hypertension monitoring program and its pressure points. Number 1, understanding the patients served, and we were able to, they identified patients that are just in our clinics from across the street, over 131 patients, and also patients with significant hypertension or postpartum who actually became part of this clinic. In that, the interventions included identifying the poorly controlled, referring them to our pharmacy program, so they actually had a connection not only with their caregiver, but also another resource that actually would evaluate their overall medical plan, ensure that they actually had their medications, and if there was a deficiency or an inability to pay for medicines, thinking about the opportunity and the pathway to make sure that their medicines were actually paid for, and then followed up in regards to both locally within the clinic environment, but also given a Bluetooth cuff for blood pressure, given instructions on how to use it, both at the labor delivery floor and also in the clinic, and then being able to have those blood pressure measurements being transmitted to our EPIC database here at the hospital, so that we can have further evaluation of the efficacy of the treatment for those patients within our EHR, so that it actually would make it easier for our patients in terms of being able to transmit data, but also to make follow-up much easier for patients, as opposed to having to come in for every clinic visit. A simple phone call or a text as part of the overall coverage became important. We had programs where they not only came back on 6 to 12 week programs, but because many of our patients actually work within the health system, if they had questions or concerns or actually had blood pressure measurements that were actually elevated and need to be evaluated, all they actually had to do was actually just walk over to the clinic and actually be seen, as opposed to actually going through at times a convoluted process to be seen within the clinic environment. So a lot of good work is being done. What has also been found is actually there are significant and persistent opportunities and challenges in terms of putting together additional plans for improvement of this patient population. So the utilization of the barbershop ideas in terms of follow-up, or the medical salons, so we can get a greater, better outcomes in the community and greater expansion of these particular programs within the community environment. And also thinking through the overall supporting architecture for our patients, not only within their local environments, for an understanding of the need and for blood pressure control and its overall importance. So there's work to be done, but this is an ongoing, for us, plan for how do we resolve the issues of significant and persistent blood pressure elevation for this population that we serve. I wanted just to touch on, actually, from AHA's perspective, as we talk about health equity, that goes back to the paper from November, and also plans afoot in terms of next steps from AHA's perspective. This slide, which you may have already seen, I think is an important slide. The events over the past 20 months have been important in terms of helping define the issue and moving not only AHA, but the whole population forward in thinking about structural racism and health equity. But from AHA's perspective, this has actually been a long time in coming. It has been an issue that we have been thinking about and evolving a plan and process for since the beginning of AHA. I can tell you that one of the part of the acceleration of that discussion began actually after 2010 and within the decade of our last decade, as we looked at our 2020 goals and to be able to meet those particular goals. Plans were put in place that we thought would be effective and actually comprehensive across populations to improve the overall blood pressure, diabetes control, and also obesity for our population, to decrease the overall morbidity and mortality from cardiovascular disease and cerebral vascular disease. What became quite profound as the data began to come in was that we would not achieve our goal of 20% reduction by 2020. And the biggest reason was that distinct populations, our population, the brown and Black communities, we were not reaching as nearly effectively in terms of management and reduction in those particular risk factors. So to the point that we actually could achieve our goals. So there was self-realization and a self-examination of the why behind the constructs we had put in place across the total population, and an understanding about what we needed to do to a greater extent to actually reach everyone in a way that helped us achieve the goals, not only short-term and long-term. And that led to a summit that I was happy to be a part of, and about social determinants and health equity for AHA, and recommendations to the executive board, and which led to the development of a health equity group within AHA to lead in thinking about these particular measures. That ultimately also has led to the paper that we discussed earlier in this particular talk. So, the burning platform, of course, is that when you think about age-adjusted cardiovascular mortality by race and ethnicity, there has been improvements over the past, over the beginning of this particular century. Those improvements have been actually across the board in multiple populations. But one of the things that you do see is that improvements in Black adults has not actually mirrored to even close to the greatest extent across the rest of all the populations. Black adults are still 32% more likely to die from cardiovascular disease than the rest of the population. And this is the same in terms of stroke mortality. In actuality, it's actually even higher. And that, again, is probably very much related to our ability to control blood pressure, to actually have a larger impact on hypertension in our African-American communities. So from the paper, but also that has been part of the guiding structure for AHA in thinking about structural racism and health equity, that I think actually also helps hospitals and health systems should think about in terms of putting their overall constructs together, is how AHA actually has approached this over the past couple of years. And as we continue to monitor and move towards the opportunities that the 2024 goals have actually put in place. AHA actually has a significant impact in advocacy, not only at the local, but regional, national level, to actually articulate these issues, to help in terms of informing governments and local communities, to change policies, to actually improve the overall opportunities for development of care pathways for patients, to cement these in a way that actually has a broader implication for not only the individual, for populations as a whole. The idea of actually, as part of our Get Them With the Guidelines program and quality improvement programs, to actually insert and put in place issues and questions about health equity and social, and how the institutions are actually addressing social disparities for them to actually achieve Get With the Guideline higher status, I think is a unique opportunity for AHA, and is something we actually are imparting. Leadership is key for AHA, and leadership in terms of actually being out in front and hoping to address these issues, but also thinking again inwardly and asking ourselves in terms of overall, from a historical narrative, how we have developed our own plans in regards to all of these issues. It's overall evolution, the evolution of AHA, and also to think about and put goals in place for our own for our leadership, and also for all who work for us, to actually surround opportunities to advance health equity, and also the issues around racism. And this actually is also towards human resources and our business operations. And importantly for AHA, the opportunity to develop science around the issues of health equity and racism are incredibly important. It's a unique opportunity for us to really have a really basic, granular level of understanding the whys behind it, but also the opportunities in terms of programs that can be developed to actually measure their overall outcomes, and to be able to put in place and recommend at both at a national level, really at an international level, those things that actually work, and really think through those things that don't. So that's really part of the work of AHA. And from that, I think both hospitals and health systems will be able to use that particular, this pathway, but also use the information that we are actually working towards developing as a way to actually put as part of their blueprint to improve the overall equitable nature of the care that we deliver for patients. So I'll end here and happy to answer any questions. This is actually a picture from Washington, D.C. I was there this summer. This is actually, we were staying at a hotel close by, and this is Black Lives Matter Plaza, which is really literally right across the street from the hospital. And it was a reminder to me of all of what has happened over the past 20 months. The work that we all have been enjoying and doing, and sort of understanding, thinking through and thinking about what is the next place to get us to a better stage, and around health equity for the whole population, and thinking through how we as an institutions can address all of these important issues in a way that are important for every patient who walks through our double doors. So thank you, everybody, and I'll stop there and be open for any questions or comments from anyone on the Zoom.
We do have a few questions and comments in the chat box. The first is, I would appreciate thoughts on increasing representation in health organization leadership and reducing the excessive debt of medical training for minority physicians and all physicians, which limits the pipeline of minority physician providers.
So there's two great questions. The first would be that as we think about within organizations developing a structure that is keeping track of and evaluating how we are hiring and actually bringing along, in terms of professional development, individuals within our own institution or actually in our Black and Brown communities, and also when we think about recruitment, I think is incredibly important. And I use the word intentional, and intentional for me, it means that it has become part of, at the very top of thinking about each and everything that we actually, each and every initiative, each and every opportunity that actually comes to the forefront for us, so that we are not actually coming back to it as an or by the way, or, you know, something we forgot about the fact that when we did this particular hire, or we did this actually from an organizational standpoint, started this new program, we did not take into consideration diversity, equity, inclusion, which for any institution at this point, their understanding is that that gives us greater strength, it gives us greater capability to actually solve these issues and improve our overall lot. Now, the issue around the debt is something I think that we are doing in a very much in a patchwork way, right? We have medical schools across the country who are actually, from a philanthropic standpoint, trying to do a large investment to actually to decrease the debt burden, to really obliterate the debt burden for any individual physician or medical student who actually comes to their organization, which I think is important, but we need to be thoughtful about. We need to think about actually the issues around how we can marry service within our healthcare organizations, and actually both a local and national level, as an opportunity for investments and individuals, and especially who are in our Black and brown communities, who actually become part of the medical school continuum, to actually decrease their overall debt burden as one opportunity, as additional opportunities. And we actually also think about the overall cost of medical education, and importantly, what that means not only now, but also in the future.
Thank you. We have another question. I do not feel there is enough focus in physician training and after on implicit racial bias. I think it drives a major part of health inequities in control of all conditions, even with providers who are minorities, since so many clinicians treat patients based on the modeling seen in their training. Are they easily accessible programs for providers?
So it's a great question. The answer is probably no. I think, but there is now an understanding that work has to be done. So a couple of opinions. Number one, the work around implicit bias needs to start at a very early time in our medical education. So I think across the country, what you're finding is that medical school education, they are now putting implicit bias programs and classes as part of the medical school curricula, as part of the development of your capabilities as a physician, which I think is incredibly important. I think both hospitals and health systems are now also providing training in implicit bias as part of the day-to-day work, day-to-day evaluation that I think many of us are ascribed to and have to take during the year. My opinion is that actually is a good start. I think it has to be a part of actually of each and every moderate to large conversation across our health systems that is led by leadership, with an understanding that we as individuals may have that bias, to actually acknowledge that, to bring greater degree of expertise to those particular meetings, to discuss it, to give an opportunity to give a pathway for the individuals as part of the larger organization to not only understand what their biases are and how they can overcome it, and ensure that it's really part of the learnings and skills that we are developing for our trainees across the system, and have it actually as one of the things that it should be of paramount importance.
We have another question coming in. This is a two-part question. How can community-based organizations work with healthcare organizations to better address health equity? And how can this framework translate to community-based organizations?
Yeah, so I can speak to examples here, in that one of the important part of the work of the development of our Diversity, Equity, Inclusion Council was then going out and actually identifying organizations in the community who were also doing work and improving the equitable opportunity for care for our patients. So identifying those institutions who actually had expertise in developing housing and transportation and improving the overall education for the population on top of what was being done by the city and by the state. Those institutions actually who were trying to address nutrition. How could we actually not only support them from a financial standpoint, but also support them from a people opportunity to actually invest in their work, to actually contribute in their work in actually ways that the expertise that we have actually enhances the overall capability and opportunity of the work that they were doing. So we have we've developed partnerships with a group called CONCAT, and CONCAT actually goes out into the community and actually identifies individuals who want to actually become part of and develop skills that actually are incredibly helpful in the healthcare environment. Technicians, laboratory technicians, x-ray technicians, phlebotomists, and others. Skill sets they don't have, skill sets that they need, skill sets that actually we can help teach in that particular environment, but also after identifying those individuals, thinking about pathways in terms of additional professional development after they actually become part of our system. I think that has been incredibly important. And then, there are, multiple opportunities in terms of housing. We have developed actually a respite program with our homeless shelter here, Columbus House, where we have made the investment to bring our electronic health record system plus clinical evaluators who are there actually within their particular environment to address the needs of a patient population that actually comes to our emergency room on a daily basis, gets acute care, but then leaves us and then comes back just the next day or the next week with actually problems that actually may have been multiplied. How do we actually address those issues to a much greater way? And this is a pathway that we have used. So investing in and coordinating an opportunity within our hospitals and health systems to go out and find those organizations and then develop those partnerships and then think through not only the financial support, which actually many of them ask for, but also the people support and a greater degree of intellectual heft that we can actually bring to the table to expand our overall capability to address these issues. I think it's incredibly important.
Thank you very much. And that concludes the questions that we have come in through the chat box. If there's anyone who still wants to ask a question, you can still put it in the chat box throughout the rest of our program and we will save it. Thank you, Dr. Churchwell.
Thank you, Lisa.
Thank you so much, Dr. Churchwell. That was a fabulous presentation. Your leadership is inspiring to all of us. Thank you so much for joining us today.
Well, thanks for the opportunity, and I hope the rest of the symposium goes well for everyone.
Thank you. Folks, we are going to take a 5-minute Move More break. You're going to see a video come up. Take that time to stretch a little bit before we come on back for our New York State Target BP Quality Improvement Recognitions. And then we're going to dive into our closing keynote for the day. So we're going to go off video now, put up a 5-minute exercise stretch break for all of you. And I hope you enjoy it. And please join us back here in 5 minutes for our recognition program.
Now it's time for your flexibility block. It's a 5-minute block with 5 stretches. Flexibility improves your range of motion and it can help you to reduce stress. Give your heart some love right now. So your first stretch is going to be your standing quad stretch. You're going to hold on to something if necessary. Beautiful. Your second stretch is going to be your back and shoulder stretch. You're going to hold on to that chair, reach down, feel the stretch in your lats, your back. Beautiful. Now, we're going to have a seat in your chair, and we're going to do an overhead lateral reach. Beautiful. Getting those obliques, your sides. Make sure you're holding 2 to 3 seconds, full breaths throughout these stretches. Next stretch is going to be your seated spinal twist. Hold on to the back of that chair, Really looking back over your shoulder? Great. Last one is your overhead tricep stretch. Put your hand right in the middle of your back. This should feel really good after everything that you've done so far today. Beautiful, you guys. Now that you've taken care of your heart, you've taken care of everything, enjoy the rest of your day. You have the rest of the day to be comfortable.
Congratulations to all of our recognized New York State organizations. If your organization is interested in participating in Target BP, at the close of our summit today, there will be a brief event evaluation that will provide you an opportunity for you to connect with an American Heart Association staff to learn more about the program and how you can get involved. Today is World Stroke Day. Stroke remains the number 5 leading cause of death in the United States and the leading cause of disability in older age. A stroke may have slowed down Olympic legend Michael Johnson, but responding fast sped his recovery. Here's his story.
I didn't know what was going on. Yeah, that's life. You just never know, what's going to happen. And the expectation, if you had asked me before, I would think if you're having a stroke, you probably know it when it's happening, but you don't. I stumbled. I had a lack of coordination in my left ankle, that I was feeling some tingling in my left arm. So my wife and I discussed it and decided, let's go to the emergency room just to be sure and see what's going on. The first thing they did was a CT scan, and they mentioned that it seems like maybe you had a stroke, but we're not seeing that. The next step was then to undergo an MRI. When I got out, tried to get off the table and try to get to the bed, I couldn't walk at all. I couldn't stand. My first question was, will I be able to recover? And the team of doctors said that is the question that everyone has, and it's the right question, but unfortunately there's no specific answer for that. But when you can't move something, you want to know, is this my future? I was very fortunate there was no brain issues. When the therapist came to my room and get you up with this walker and ended up walking 200 meters or thereabouts, which was ironic given that I was the fastest man in the world at that distance. It probably took 10 minutes for me to cover that distance that day, but I wasn't discouraged because I was taking instruction from my therapist the same way I took instruction from my coach. And it's what made me return to my room and tell my wife, I'm confident I'm gonna make a full recovery. I was truly having to learn how to walk again. My motivation was phenomenal. My son is just going off to college, actually. I want to obviously be around for him and grandkids if I'm so lucky to have them, and I don't want any restrictions. I want to get back my quality of life. This was different. It was all of a sudden going into therapy and going into the gym every day, twice a day, with a real motivation. Nobody's clapping. There are no gold medals when I finish, of runs on the track or in the weight room. That's a greater motivation than winning an Olympic gold medal, to be honest. Now it's more of trying to make sure that I take the time to relax, even if I don't feel like I need to. Relaxation for me a lot of times is go do a workout. Just sit down, And I do that a lot more and meditate, and that's good for me. Being a stroke survivor is part of who I am and always will be. I'll never know what caused this stroke. All I can do is do all that I can to minimize my risk of a stroke and live my life.
What an inspiring story for World Stroke Day today. If you would like to learn more about World Stroke Day or access any of our tools and resources about World Stroke Day, please visit heart.org/World Stroke Day. It is now my pleasure to transition us into our closing keynote. Our final speaker today is one of our leaders at the American Heart Association. Dr. Eduardo Sanchez is our Chief Medical Officer for Prevention, as well as serving as the principal investigator of the National Hypertension Control Initiative. He is also the American Heart Association's clinical lead on Target BP, and the No Diabetes by Heart initiative. Please welcome Dr. Eduardo Sanchez.
Hey, everybody. So pleased to be here. It already was an outstanding day, outstanding morning for me. I'm calling you from, or talking from Dallas, Texas. But Michael Johnson is one of my personal heroes. I tried to run track in high school, and I follow the sport. And oh my gosh, what a moving testimonial. And I was really pleased to see so many of our health center partners recognized for what they are doing to achieve better blood pressure control. And so I want to congratulate and thank them. I have a little bit of New York in me. For 5 years, I lived in New York City, in Jackson Heights. I attended PS 148 and PS 127. And so there's a little bit of joy and pride today that I'm feeling as I hear the awardees listed out. I also want to thank all the participants. Really was outstanding. If the breakout sessions that I didn't attend were as good as the ones that I did attend, oh my gosh, it just has been really a great morning. I have every confidence that other persons at AHA who haven't had a chance to hear or participate will get to and will be seeing those recordings. Just outstanding. And I want to thank the AHA staff and volunteers who helped put this together. This really has been a great day. I come away smarter, which is always a good thing every day. It's part of my own personal quality improvement. Dr. Zucker set the stage for our day, and Dr. Rakotz set us up, gave us a really nice grounding in MAP and some of the work that's being done to improve accurate measurement, rapid action, and partnering with patients. I attended the session on remote patient monitoring and just want to say, Community Healthcare Network, you got it going on, and I'm looking forward to reconnecting in other ways and connecting our folks to the work being done. And then the health improvement, the health information exchange session was really, really good as well. I learned some new acronyms, SHINY, HICSNY, and then Healthy Connections. All three organizations presented, and just so much going on at the state. I'm excited as a family medicine residency trained physician, but also a trained and experienced public health physician. I had the great privilege of serving as the state health officer in Texas. So seeing this conversation that's included the words public health, the words population health, and the words clinical care are so important. And I was thinking today that back when I was commissioner, I used to talk about primary care docs doing public health through their vaccination efforts. Primary care docs are doing their public health efforts through blood pressure control efforts as well. So it's just been a great day. And I'd say in the spirit of disclosures, my only disclosure is that I'm a champion for health equity along with everyone else at the American Heart Association, and that I'm a strong proponent of blood pressure control. So I'm going to move through some slides today that I hope kind of bring everything back together and close on what I think is a note of a positive note. One thing that I've thought about here a lot lately, and I keep hearing these themes, blood pressure control is a team sport. And we certainly have heard already today about all the different positions, if you will, that are playing towards victory. But I would also say that blood pressure requires playing the long game. And sometimes you lose a game. Sometimes you even might have a losing season, but you come back to become that dynasty that's gonna, in the future or soon, win year after year after year. We at the American Heart Association, along with other partners, American Medical Association, some of you have been on this call, and I got to stop for a second and just thank Keith Churchwell Keith Churchwell for his leadership in so many different ways. Also a very inspiring and really, really great presentation. But we are about translating science into resources, and then those resources being translated into action along with everyone else. I'd say that's part of our playbook. Next slide. You heard already that the American Heart Association has stood itself up to be champions for health equity and do everything it can so that every person has the opportunity to live a long, healthy life. And we are going to focus in particular, not on this slide, but one of the areas of focus is blood pressure control. Next slide. Interestingly, or very appropriately, Dr. Zucker kind of framed things in terms of COVID-19. And I want to do the same, coming at it slightly differently. In 2020, the list of top 10 causes of death, unlike any lists of causes of death prior to that in this country, included the COVID-19 as a cause of death. It was the third leading cause of death in the United States of America. Approximately 350,000 people lost their lives due to COVID-19. But that's not the whole story. And the reason I wanted to have all causes is that in virtually every single other category, more people died in 2020 than died in 2019. So COVID-19 not only was a force of destruction, but it left a wake of destruction behind it. The narrative that one sometimes hears or sometimes heard that, well, people die of something. Well, they died of COVID-19 and everything else. COVID-19 did not become the thing that killed somebody. Instead of, it just became a big, big cause of death. Next slide. That's also true regarding deaths from hypertension. Although it doesn't make the top 10 list, there was a 14% increase in crude mortality rate due to hypertension and a 12.4% increase in age-adjusted mortality due to hypertension. Next slide. We heard about hypertension prevalence. And these are numbers that aren't exactly comparable. The national data are NHANES data, and the New York State data come from BRFIS. So they're not exactly the same. They are in the right area. We heard from Dr. Zucker the prevalence data by race ethnicity in New York State, and for African American persons, substantially higher than 30%. And for white persons in New York State, it was around 30%. Next slide. So I did prepare by looking at the New York State prevention agenda, the state's health improvement plan. And I'm not going to go through this. I just want to highlight some areas of convergence between what's in that plan and the work that we are collectively doing to improve blood pressure control. At the bottom, where you have focus area 4, preventive care and management, you can see that increasing early detection of cardiovascular disease, diabetes, prediabetes, obesity. I'd say hypertension ought to be explicitly listed, but I won't quibble. Promoting the use of evidence-based care to manage hypertension and improving self-management skills, all things we've heard about today. And yeah, I'm at home, so I'm going to step away, let some dogs out, and be right back. The other two areas that are always so important to remember are the non-pharmacological, the lifestyle areas, or behavioral areas that can contribute to better or not so much better blood pressure, healthy eating and physical activity. Next slide. Now we heard a little bit again about COVID, and let me just capture it here. This is high blood pressure control levels in HRSA-sponsored health centers, the 1,400 or so formerly called FQHCs. And let me do one more full disclosure. I came up in the federally qualified health center in Austin, Travis County. That's where I learned to be a doc. That's where I learned to care about things other than just what was going on physiologically and writing the prescription, and beginning to appreciate that context really, really does matter as it relates to partnering with patients to take care of them. But what this shows you that I know y'all know is that whereas from 2016 to 2019, we saw some incremental improvement in blood pressure control across the 1,400 health centers, 2020 came along and boom, there was a dramatic drop in blood pressure control for all reasons that we've heard from a variety of speakers today. Next slide. So I'm going to talk a little bit about this paper that came out in 2020. Paul Muntner was one of the lead authors. You'll see other names that you recognize. Paul Muntner was one of the authors of the 2017 hypertension guideline that was written by American College Cardiology, AHA, and really a list of other collaborating organizations. So let's go to the next slide. What I want to talk about are some of the social determinants of health issues that have been addressed already today, but put them in the context of blood pressure control. In this, here as I talk, blood pressure control is going to be a blood pressure below 140/90, the NQF-18 measure. And I've highlighted in red where I want to talk first is that the blood pressure control rates, at least according to the NHANES data for these groups that were captured, blood pressure control is higher among white persons, substantially higher than the other three groups for which data is represented, where the blood pressure control levels hover at about 41% for the three other groups as compared to non-Hispanic white persons with high blood pressure. Next slide. And this is where I wanted to focus a little bit of attention for today. Education matters. So having less than a high school education correlates with the lower blood pressure control prevalence. Income matters. I don't think it would surprise you that having less than 20,000 annual household income correlates with low blood pressure control. The kind of insurance you have, if you have it, matters. You can see that Medicare, persons with Medicare have higher blood pressure control than persons with private health insurance, than persons with Medicaid. Patients with Medicaid control, but a drop off from private health insurance and Medicare. But in red, I want you to see that uninsured is a much lower level of blood pressure control. And whereas y'all are in New York City and New York State, I mean, and enjoy, and I think that's the right word, a low level of uninsurance at the state level. I live in the state with the highest uninsurance rate in the country, the highest number of persons who are uninsured in the country, and I dare say way too many people whose blood pressure is not controlled. So from the national frame, the American Heart Association, the American Medical Association are mindful of opportunity of Medicaid states that have not expanded Medicaid to do so and increase the opportunity for persons with hypertension to get their blood pressure under control. But I would be remiss if I didn't go to the very last row. And if you have not seen a healthcare provider in the past year, your level of blood pressure control is really, really, really low. And so again, it's the reminder that one, let's get people insured. And two, let's make sure we keep them connected, tethered to the clinical care delivery system, just to make sure that blood pressure stays controlled. Next slide. I noticed in the state health improvement plan an ecological model for health. This is an ecological model for hypertension control. And I'm going to talk about a few things that are going on that are reflective of blood pressure control efforts at various levels of this ecological model. Next slide. I think that all of us are pleased. We wish there had been more, but all of us are pleased that the FDA has released some voluntary sodium reduction goals that are aiming to reduce sodium to 3,000 milligrams per day from what is now 3,400 milligrams per day by addressing at a high level, contextual level, commercially processed, packaged, and prepared foods. So this is for industry to begin reducing the amount of sodium that's in our processed, packaged, and prepared foods over the next 2.5 years. I want to focus on the impact. This is based on some modeling. Reductions in intake from where we are now to 2,200 milligrams per day would have an estimated result of tens of thousands fewer cases of heart disease and stroke, as well as billions of dollars in healthcare savings over time. And again, this is a reminder that blood pressure control is a team sport, and that team sport involves all kinds of levels of effort to play the game and win the game. Next slide. I hope y'all are all familiar with the community guide. I wanted to do just a quick review of the community guide's recommendations around cardiovascular disease. And I'm just going to focus on the ones that have recommended strong evidence. Team-based care to improve blood pressure control. There's that team word again. Interventions that engage community health workers. We are underutilizing community health workers. And since my time as a family physician in Austin, Texas, and my time as state health officer in Texas, I have been a huge proponent of community health workers as part of the team. Reducing out-of-pocket costs for cardiovascular disease preventive services. In other words, making it no or low cost for blood pressure medications would be a really good thing to do. Tailored pharmacy-based interventions to improve medication adherence. We heard a little bit about that from Keith Churchwell. I'm going to talk a little bit more about it here in a moment. And we also heard about self-measured blood pressure. And when it's combined with additional support, it is recommended with strong evidence. Next slide. Yeah, I'm letting the dogs in now. So this is just a quick reminder that the great late Ron Victor was trying to figure out with science what might be some approaches that would help us improve blood pressure in among folks who are hard to reach and don't engage in primary care as much as they could. Community setting, study, cluster randomized trial, blood pressure reduction in Black barbershops. Here's the important part. The intervention was barbers were encouraged in meetings in barbershops with specialty trained pharmacists who prescribe drug therapy under a collaborative practice agreement with the participants' doctors. And bottom line is systolic blood pressure decreased substantially, 27 millimeters of mercury. 63% of participants achieved blood pressure levels below 130/80, 95% cohort retention rate. Next slide. You heard about MAP, so I'm not going to spend much time talking about it, except to say that we are pleased to be partners with the American Medical Association. We are pleased to be working to put the structure and processes in place that make it possible to take the what that's in guidelines to the how of achieving blood pressure control. Next slide. Target BP award summary. So again, congratulations and thank you to those awardees from New York State. And this very busy slide, I think, but one that I've used. Let's focus on the things that are worth focusing on. One is that if you look at 2021, the column for 2021, the numbers of practices of healthcare organizations that submitted data and achieved gold plus is down from prior years. And that, again, shouldn't surprise us given what we saw going on from the data I showed you guys in the HRSA-sponsored health centers, but also the things that we've seen going on in all other healthcare settings in the United States. Next slide. So I have the great privilege of serving as the principal investigator for the National Hypertension Control Initiative, but more importantly, I have the great privilege of partnering with so many people, working with so many people at the American Heart Association, where we are stretching ourselves beyond target BP, and with this funding that's come from both the Office of Minority Health and the Health Resources and Services Administration, we are providing training and technical assistance to 350 HRSA-funded health centers that have, in addition, received $60 million for self-measured blood pressure devices and a few other things related to blood pressure control in those health centers. The 350 health centers, and then you'll see on the slide, another 146 that received funding, but are not going to be getting the training and technical assistance from the American Heart Association, at least as of yet, are health centers that were not performing as well as the others. They had levels of blood pressure control below 60%, and HRSA felt and OMH felt that there was tremendous opportunity to bring their blood pressure control levels up with interventions and resources. Next slide. Our approach is one that this is the best I could do with an ecological model and my skills with putting together diagrams. But what you can see is this is very patient-centered. We want to make sure that the clinical care around that patient is high quality, guideline driven, evidence-based. And we also have a very strong component that involves connecting with community through partnerships with community-based organizations and leveraging platforms, social needs platforms, such as Aunt Bertha, Unite Us, and not yet any of the ones that I heard about today, but not unlike some of the platforms that were discussed in some of the sessions that I participated in. I do want to note that leadership and evaluation are critically important. Leadership on the one hand, that goes all the way to the top of Nancy Brown, the CEO of the American Heart Association, Marielle Jessup, the Chief Science and Medical Officer, and so on and so forth. And it also includes a very strong evaluative element. We can't learn if we don't monitor and track what we're doing. And that is on top of a foundation of health equity. Again, I did my best to capture this on this slide. Next. We've organized our training and technical assistance in this, I would say, this kind of nested approach where we are providing national webinars on a particular topic, followed by associated with workshops that are meant to be more hands-on-ish, more peer learning, more about how to do it rather than hearing the what. The office hours are to reinforce both of those, and then what we have available one-on-one technical assistance. Next slide. This slide shows the 8 areas of focus for this year, using again that nested approach. We are on the back end of the work that we've done. Our plan for year 2 is to build on this foundation and go beyond just we call these the basics, but felt that these basics were critically important foundational elements to then build. And they're all the things you've heard of. Using data to monitor performance and improve performance, measuring accurately, acting rapidly, partnering with patients. And this month and next month, we'll be talking about lifestyle change with a focus on nutrition, physical activity, and medication adherence. And next month, we will be focusing on social determinants of health, not just as a topic, but the opportunities for addressing those and improving blood pressure control as a result, with community-based organizations involved. Next slide. So I had the great privilege on Monday and Sunday and Monday, at being at the American Public Health Association meeting, where, oh my gosh, there was another set of just such inspiring speakers. These are speakers who you sometimes see on the TV. Heather McGee, who's the author of The Sum of Us, Georges Benjamin, who's the CEO of the American Public Health Association, David Satcher, a former not only US Surgeon General, but CDC Director, Assistant Secretary for Health, and then Bill Foege. And Dr. Foege was a CDC Director and was somebody who's been credited with being principal, if not the person who helped eradicate smallpox in the world. And there were some things they said that just resonated, and I think set the stage to me finish up. One, we pay a price for inequity. So we heard Dr. Churchwell talk about the ROI for equity. The truth is there's a loss that we experience every single day in this country because of inequity. And I would say to you, think about the data that I presented to you about blood pressure control and social determinants of health. People are dying because we can't get their blood pressure control, or we can't collectively get their blood pressure under control for a variety of reasons that make that challenges that we need to address. Another phrase I heard, what we can do is clear. And I would say that as it relates to blood pressure control, what we can do is pretty clear. Let's use the MAP framework. Let's hold ourselves accountable to improving blood pressure control. Let's partner with patients and communities to make it possible, make conditions hospitable for better blood pressure control. We have to persevere until the job is done. That was Bill Foege's line. There are sometimes headwinds. There are sometimes opponents in this team game that will beat us this year, but we're going to beat them next year. Or they're winning in the first quarter, and we will win the game in the fourth quarter. We're always swimming against the current was something I heard. And as it relates to blood pressure control, right now we are swimming against a pretty strong current. You know, let's just keep our arms moving and keep our eyes on the prize and keep moving. Now I'm talking about swim team as opposed to field team. I heard be courageous, and this takes some courage, particularly the part about health equity, and particularly the part about dismantling structural racism. That takes some courage, and it takes some spine sometimes to say what needs to be done and to speak truth to power. So I'm going to close with this quote that y'all might have been looking at. It's a quote by a guy named Hans Rosling, which I just think is so fitting. I'm not an optimist. I'm a very serious possibilist. And already today, we've heard about tools, we've heard about resources, we've heard about best practices, we've heard about things that people are beginning to pilot with everything in mind to scale up and scale out. And I just believe that I want to leave myself anyway, and leave y'all with the thought that we can achieve what we set out to achieve. And this COVID-19 was a little bit of a setback, but we were moving up. We were moving up in blood pressure control. Let's double down, get back to where we were in 2019, and then continue our progress towards 2024, 2030, and beyond. Again, I thank each and every one of you for what you do every single day to make a difference in people's lives. I thank and congratulate those that were awardees this year. I want to encourage those that are not to get with it and get awarded, get recognized and be awarded next year. I want to thank participants who were just so awesome. And I want to thank AHA staff and volunteers who helped make this happen. Thank you very much.
Thank you, Dr. Sanchez. We do have a hand raised for a question. Ian, excuse me, Ian Cole, if you would like to ask your question, go ahead.
Ian, if you're talking, you're on mute.
No question to ask.
All right, then we will move on to some additional questions. With that scary 8% control rate for those who haven't been to the doctor in the past year, what can we do as a community organization to encourage people to go beyond just telling them in a community blood pressure screening that their numbers are high and they should get checked by their doctor?
Wow, that's such a great question. And I'll just relate a personal story. So many years ago, I first got involved with the American Heart Association when I was working in a community health center in an FQHC in Austin, Texas. And I was also the local health officer for the Austin Travis County Health and Human Services Department. And we put on a first-time Hispanic health fair. Became one of many. I'm a person who believes that health fairs are a good start, but they're never the finish. But to your question, I felt very strongly then, have felt very strongly since, that it is not enough to screen somebody for anything and then say, got some bad news for you, go figure it out. I think it would be really great if community-based organizations that might already have relationships with community health centers and or might think about cultivating those relationships so that when those folks are found, a very warm handoff could be accomplished, where perhaps an appointment's already made, that would be one part. And then the other is to apply the motivational interviewing skills that we have to spend a little bit of time with that person and see if we can nudge them along to saying, I am going to show up and get that taken care of. Great question. I'm not saying that what I just said is easy to do, but it is a way to go about it. I also think that if that person was willing to share a little bit of personal information, cell phone or email address, it wouldn't hurt to check with that person a week or 10 days later and just say by text or by call or otherwise, have you taken that next step?
Another question coming in, how can the American Heart Association help connect community and clinical assets?
That's a great question. And the better thing is that I hope I have a great answer. So with the work that we are doing with the National Hypertension Control Initiative, and I really didn't want to spend a lot of time talking about that, but I'll spend a couple of minutes elaborating. We think of three, I don't want to say pillars because pillar sounds like they're separated, but they are three lanes that are interchangeable that include patient-centeredness, include community, and include clinical care setting. And one of the things that we are very much trying to realize is to build that community health center, community-based organization relationship using a platform as one of the bits of glue, using local champions to serve as connectors. And we have deployed our own community impact staff as well as public health managers is what we're calling them in the National Hypertension Control Initiative, to kind of nurture and cultivate those partnerships between community-based organizations and clinical care settings.
Thank you very much. That wraps up our questions.
Dr. Sanchez, thank you so much for joining us today. That was amazing. And like others, that 8% statistic is very scary. You are an amazing Heart Association representative. Thank you for being here today. Again, for folks that did have questions, I believe we're going to put that National Hypertension Control Initiative link right in the chat box. For folks, there are some great tools and resources there that I think people might really take advantage of. Thank you. We could not have hosted today's summit without the support of our sponsors. Again, a shout out to our regional sponsors, St. Joseph's Health and Mount Sinai South Nassau, and our track sponsor, Healthy Connections. We do invite you to join us this February as we launch our next annual Check It Challenge. The Check It Challenge is our 4-month-long program that empowers individuals to self-monitor their blood pressure and encourages healthy lifestyle choices, so many of what you've heard about today. Pre-registration is now open for that program, which you can get to by going to heart.org/checkitchallenge. We appreciate all of the time that you have given to your presentations today, staying with us in this main room, getting out to your breakout sessions, and also coming back into this room with us. We know there's some technological challenges here and there. Please know that you will receive an evaluation as soon as this webinar closes today. We would love it if you would fill that out for us and help us make improvements for both this summit and future events and activities. Please take what you have learned today back to your communities and help us be a relentless force for a world of longer, healthier lives. Thank you and enjoy the rest of your day.